you should all be able to see the presentation. Can you all see it?
Mom, yes.
Wonderful. Okay, so for the next half an hour, and I've just looked at the clock, starting at 10:02, so we'll be out on time. We are going to talk about Guillian-Barre. So we're going to go through a little bit to do with the pathology of Guillian-Barre. We're going to talk about the awareness of potential complications that the patient can have when they've got Guillian-Barre. And we're just going to work on just improving the way that we care for these patients, because actually what I want you to take away from this session is ultimately these patients, they go on to do very well, and the majority of them make full recovery. So the nursing care that we give them is just so important. All that basic, lovely nursing care of looking after a ventilated patient is what really makes their care and their experience better. So just a little bit about Guillian-Barre. So Guillian-Barre, it's a disorder that affects parts of the immune system. So it just causes this weakness. But it's like this weakness that kind of affects the person's respiratory muscles to the point where they can't breathe. It's when the body is fighting something like the flu, it then does a really good job fighting the flu, and then the body then turns on itself and continues fighting. And what it does is it destroys part of the nervous system, which means the messages for the muscles to move aren't getting from the brain to the actual muscles because the myelin sheath is destroyed. Why it happens is not fully understood. It can be obviously said can be caused by the flu, but it can be also caused by something like food poisoning, a flu vaccination. It's not just your, any kind of infection. So whether it's bacterial or viral, there's anything where the body's had to fight for something, it then turns on itself. From a demographic point of view, thankfully it's quite rare. We see it a lot because we are in a neurointensive care unit, but it's rare. Anyone at any age, although if you're older, you are more affected by it and you're less likely to come out of it completely unscathed the other side. It's not contagious. We can't catch Guillain-Barre from anyone. And it's not known why it strikes, but men are more likely than women. But you do see women with Guillain-Barre as well. It's not that you don't see them, because you do. It is an acute onset. So this person will be at home and they will have whatever virus they have. They'll then feel like they're getting better, and then this will then kind of like to floor them. It's usually kind of, it can be potentially life-threatening because obviously it affects their capacity to breathe because it affects their respiratory muscles. And like I was explaining, and I've got a picture a bit later on where it damages the myelin sheath. And because it damages the myelin sheath, all their messages that we use, and the myelin sheath acts as our insulation. So from axon to dendrites, it's the myelin sheath that insulates it to make sure that all the messages get passed. If we've got a breakdown in our myelin sheath, bits of the message leak out along the way, which means the message, it's like Chinese whispers, only it's really, really quiet Chinese whispers. And by the time you get from one person in the line to the other person, it's saying completely the wrong thing because you can't actually hear anything because too much of the information is being leaked out. There you go. It also affects the brain's ability to interpret things like pain as well. So these people, they feel a lot of neuropathic pain, and that needs to be really considered because not only are they conscious, they're also feeling neuropathic pain. Here's the picture I was talking about. So this is what it does. So you've got your myelin, and the body has attacked its own myelin sheath. So this autonomic condition. It really, I mean, the more you think about it, it's really, for the body to do that, it really isn't very clever, but that's what it does. So from a clinical presentation point of view, so it's sensory with distal paresthesia. So it originally starts with them, usually the most common one is the ascending Guillain-Barre. So it starts in the patient presenting with leg weakness. It then moves up their legs into their chest, and they develop respiratory weakness. And we're talking about when these patients are at their worst, they can't even open their eyes. So they can't even lift their own eyelids. So they look like they are comatose. They look like they are locked in. because they can't even open their eyes. And if you imagine how to be a patient and to be like that, how that would feel, it's really quite scary and yeah, just generally awful. So yeah, so it presents with pain and numbness and this ascending kind of weakness. And they're usually at their weakest 3 weeks. So it takes 3 weeks to ascend properly. There are other variants, which we have seen recently. We recently had in the Seidman and Miller-Fisher variant, didn't we? He was a boy. A boy. Other clinical features are the abnormal reflexes, swallowing weakness. So if the respiratory muscles aren't going to get you, so if your inability to breathe in isn't going to get you, then your swallow will, because you'll aspirate. Yeah, aspirating equals chest infection, and they're already weak, and it all goes round and round. So ophthalmology, so we've mentioned them unable to move their eyes, so unable to move their eyes from left to right, and they just focus like doll's eyes, and they can't even, and then you have to open their eyes for them. Respiratory muscles, yes, fine. Autonomic involvement, they can develop like low blood pressure and high heart rate if they're dehydrated, if they're getting septic, because they can have other complications. They can have complications with PEs because they're not moving around as well. They can have a lot of complications. Facial weakness, yes, not being able to move on, not being able to smile. I mean, pain, we know, we touched on this neuropathic pain, but it can be really significant for them. Appear comatose with absent brainstem reflexes. So they can look brainstem dead. And then the sensory, so sensory impairment. So some of them are going to be hypersensitive as well. They're going to be oversensitive because their body doesn't know what to do and all these messages are confused. So they get this hypersensitivity and this pain and generally a confused body. Now, this slide, I just wanted to talk to you about this slide. So if you look at the red part where it says infection, that's whether they get the flu, whether they've had the flu jab, whether they've had food poisoning, whatever they've had. So they have the initial infection of whatever's going to cause their issue. Their body then makes these antibodies and continues to fight. So then the blue line is the body continuing to fight. And then the green line is the progression of the Guillain-Barre. So as you can see, the infection, and then it's the cells being these antibodies being generated by the body that then causes the rise in the Guillain-Barre. And then at the top of that, you have, if you look along the bottom, you can see it says a plateau phase. This is the phase that they have to go to. And we do try and do things to speed it up. We might give the plasma exchange to try and clean out the plasma, to try and get rid of some of these antibodies, these gangliosides. So they'll try and clean the blood to get rid of it, to try and get their bodies to start improving. Because if they haven't got the cells which are attacking the myelin sheath, then they will start to improve, because myelin sheath can rebuild itself and it can repair. So they try to shorten this plateau phase, but they do ultimately all go through this plateau phase. And then at that point, when you're in this plateau phase, our job is to be looking for a moment where they're coming out of the plateau phase. They might wiggle their toes, they might wiggle their fingers, you might see an eyelid flicker. You know, you might see something very minimal or very subtle that will mean that maybe they're coming out of it. And then different types of variants. So we've got motor and sensory. So this is more of your ascending and your descending. You can have purely motor, so that they won't have as much pain. You don't see the motor one very often. The Miller-Fisher variant is rare. So Miller-Fisher starts with the cranial nerves. So more of like the bulbar problems and the swallowing problems for your Miller-Fisher variant, Guillain-Barre. Bulbar variant as well, again, swallowing problems. And then you've got this primary axonal, which you can have this kind of like where the axons are affected and not the myelin sheath. I don't think I've ever seen a primary axonal GBS. I have seen this once, the CIDP, so chronic inflammatory polyradiculoneuropathy. Let's call it CIDP, yes. This one is basically, this means that they continually relapse. So it's Guillain-Barre, but they get it again and again and again and again. And we had a lady that came in with it twice. So that's how I know this one. And because we've seen it, and I've only seen it once as well. So the main one that you see is the ascending typical presentation of Guillain-Barre, but you do get the Miller-Fisher as well. And this CIDP is, you know, rare. And can you imagine getting Guillain-Barre again and again and again? It's just awful. So you do have to find out and exclude other causes. So is there something else that's causing this bigness? Yeah. Is it symmetrical? So is it the same on both sides? If it's the same on both sides, it's more likely to be Guillain-Barre. ENG studies, they'll want to do nerve conduction studies to see if it is. They'll also want to do things like lumbar punctures to look at the CSF, because if you've got Guillain-Barre, you have a raised protein count. And you want to obviously check for reflexes such as a knee jerk. So from the point of view of progression, once they're kind of in their weakest phase, the disease, the progression can be quite fast. So from developing the weakness to it then moving up the body can actually be quite fast. 65% have fully recovered after a year. So it's a long recovery in some respects, but actually considering our brain injury patients can take up to 2 years to recover, it's actually 30% of Guillain-Barre patients require mechanical ventilation, and the others they'll be managed on Kent ward. They don't all require mechanical ventilation. The maximum neurological deficit occurs 2 to 3 weeks from onset. So again, you're just watching that kind of like increase in severity of the illness. Recovery can over weeks and months and up to a year. Around 5 to 8% mortality. So some do die. They die of complications related to the Guillain-Barre. They don't die of Guillain-Barre. So they'll die of respiratory failure. They'll die of infection. They'll die of a PE. They'll die if they've got other comorbidities that have led to it as well. They've got the Guillain-Barre itself shouldn't kill them, but a complication will. And then 80% fully recover back to normal life and to share their experience with others. And 20% will be left with a lasting weakness, whether or not it's a leg weakness or an arm weakness. If they've maybe become quite contracted and they've had a contracted leg or a foot drop and it's not been managed correctly, they're going to have a limp. So it's actually the care that we give the patients. Medical treatment, so supportive, so it's our care, our nursing care that we give these patients. It's the stretching of the limbs, it's the splints that we put on them, it's the moving them, it's the pressure area care, it's the mouth care, eye care, all of those things. It's the DVT prophylaxis, it's all of that care that we give the patients, the suctioning, the chest physio. I mean, there's a long list which we will kind of touch on. You know, they will also start with the IVIG. And I was actually asking Andrew, because I was unsure why sometimes they do plasma exchange and sometimes they do IVIG, which is the immunoglobulin therapy. And I said, well, why do you sometimes give plasma exchange and sometimes you give IVIG? Can you see that? And it actually comes down to the availability of what they've got. As a general rule, and it makes perfect sense if you think about it, and I've never thought about it before. That's why it's good to do these. It's good to do these sessions. Is they will always try to opt to do plasma exchange first, and then if they need to, then IVIG. And the reason why they do that is because if they did it the other way around, they put all the immunoglobulin in, and then they clean it all. And they're just like, you know, that makes perfect sense. I hadn't considered it. Yeah.
So it depends on availability.
It does, and the plasma exchange people haven't been doing it recently because the facility's been down. So these patients, from our point of view, they're going to need a considerable amount of respiratory support. So they're going to be the early trackies. They're going to have an ET tube in. They're going to be ventilated. They're going to need suctioning. They're going to need cardiovascular support. They're going to need advanced monitoring because we know that they can go hypertensive. They can develop arrhythmias. They can have PEs. So monitoring. They're going to need fluid management. Are they going to get? They might be dehydrated. They might need inotropes if they're really hypertensive. You know, especially at the beginning, especially because we're giving them loads of sedation to keep them sedated, which is going to knock their blood pressure down. Then we might need to give them NORAD to counteract the sedation, which we do. Analgesia, yes, they need, but they need things like the pregabalin, gabapentin, they need like the neuropathic painkillers, the ones that take a while to get established in your system. They're not instant. Sleep deprivation. Well, in an intensive care unit, we are really, really good at sleep depriving our patients. It's true, really, truly are. And then we like to send them delirious through lack of sleep, don't we? Yes. A Guillain-Barre patient, well, all the Guillain-Barre patients I have seen at some point have been delirious.
Yeah, something. The one with Fisher Miller.
Yeah.
Fisher,
See? I challenge you to find one that doesn't go delirious on you. Nutrition, yeah, they're going to need like the proteins and things. So really important dietitian will follow. Their diet is so important. Obviously, they're NG fed because they're swallow and we don't want them to aspirate. And then maintaining limb flexibility. Again, that's so important because these people are going to get better. From a respiratory management point of view, if someone's on the ward and they've got a vital capacity of less than 15 mils per kilo, or less than a litre. So less than a litre means much more to me than 15 mils per kilo for vital capacity. If their vital capacity is less than a litre, then they are going to need intubation because they're not going to be able to clear their CO2 and they're not expanding their chests enough. And then elective intubation is often better than an emergency crash intubation when their CO2 has risen. Yeah, let's don't wait for the decompensation. If their VC is low, you know they're going to get worse. You know they're going to decompensate. They haven't got their bodies haven't got the capacity to deal with this, so they're going to decompensate. Trachea early because they've got swallow problems, and they're not going to be fast weaning patients. These are slow, gentle, gradual weaning patients that will be on the ITU for a good few months. So let them settle in. Yeah, don't do anything fast. Give them a trachea, then you can turn off the sedation. Yeah, and keep them awake a bit more, which is better for their stomachs and their bodies because sedation long term isn't good for us. Weaning is usually 3 to 4 weeks post onset. So the diet you have to see some level of recovery before you start weaning them. And it's really important with these patients that you wean them slowly. They're not the type of patient where you think you'll just have a go to see how far you can get to wean them. You don't wean them at night time because they're not going to do well. Where some patients we might try, whereas these patients you wouldn't. These are your slow, gradual weans that you take time over. And also if they look like they're struggling, if they've got chest infections, if you're suctioning them more than you were before, then you're not going to push the weaning. You're also not going to try and do everything at once. You're not going to try and get them out of bed and wean them at the same time because you're going to knacker them. Yeah. Also from a respiratory point of view, the other thing I haven't said is it's a lot of suctioning and cough assist, shaking them, sputum clearance, listening to their chests, rolling them, all that really good chest physio. They're things you need your arm muscles for. Yeah. Exactly. From a cardiovascular point of view, they can get autonomic dysfunction because obviously the myelin sheath is damaged. So it depends on what part, and the parasympathetic nervous system is affected by this. So luckily it's a low number of cases. So 3 to 10% of the cases are going to have autonomic dysfunction as well. The blood pressure will fluctuate. Yeah, okay. Hypotension can be treated with fluid boluses, but again, if you're giving them a ton of sedation, you're going to knock their blood pressure down, and you might need to sedate them before they've had their trachees. So getting the trachea down early and getting the sedation off them is good. Beta blockers, again, if they're starting to go tachycardic, beta blockers should be avoided because they're going to increase the risk of cardiac arrest because they're going to drop the heart rate, and these people are already quite autonomically autonomically can't think of the word, damaged temporarily. And they might also have some pre-existing cardiac disease as well. There might be something that's going on. And they may also require a pacemaker if they're developing arrhythmias. So sinus bradycardia and tachycardia, yes, you can see either. Be careful when you are suctioning them because they might go more bradycardic, because if you're suctioning someone, you're also stimulating their vagus nerve. So that can affect their heart rate. And then heart block catheter, they may require pacing, and yeah. So from a pain point of view, we've just touched on the fact that they will have neuropathic pain and may require opiates. Generally speaking, they need the pregabalins, the gabapentins, non-steroidal anti-inflammatories. They can have those. See, everyone likes paracetamol. Other drugs used are your antidepressant type ones. So things like your carbamazepine, amitriptyline, will help control the pain. Although the current one they like to give is gabapentin and pregabalin are the ones that feature quite highly. And from a neurological point of view, we're not poking these patients all the time. If they've got Guillain-Barre, if they're diagnosed with Guillain-Barre, you know they can't move because they are tired. So don't pinch them every hour. Yeah? What is the point? You're just going to make them delirious. Back to the sleep deprivation. Yeah? So yes, a GCS baseline is important, and knowing your patient is important, and checking their pupils is important. But if they've got a Guillain-Barre, I'm not going to poke this patient. I'm not going to be pinching this patient and shouting at them, because that's not the problem. Yes. And again, you do have to do some level of assessment, but like we've said, these patients are going to change slowly, not quickly. So you don't need to do it every hour. Once they're established, they've got Guillain-Barre, once per shift assessment is okay. Yeah, let's not go crazy. Because of the autonomic dysfunction, they're going to not have the muscular control to push out poo. They're going to need they're going to need suppositories. They're going to need their laxatives. They're not like a spinal patient that need the daily PRs at 6 a.m. But they are going to need some level of input and monitoring of their bowel activity, and they will require a catheter. And because of the digestion and the muscles involved in that, and also the sedation that we're going to give them at the beginning, they can develop paralytic ileuses and other issues. Psychological management. So put yourself in their shoes. How would you feel if you were lying in bed and you couldn't even open your eyes or move your eyeballs? I would feel quite scared, lonely, helpless, vulnerable, especially if I had to trust the nurses to look after me.
You don't want to trust us anymore.
See, I'm sure you guys would leave me there. You put me in a side room and you just poke me every hour. Depression, yes. These patients, they need to have antidepressants started early, because it's going to take 2 weeks to come into effect anyway. So let's preempt this and be like, right, it's like a spinal patient. You know they're going to get depressed, so you give them the antidepressants to try and get them out of it quick. Because if they're depressed, it's going to affect their rehab. Because if they're not going to want to do things, there's no drive if you're depressed, because you no longer care. And then that has a massive impact on how well they do from a ventilation point of view, from a mobility point of view. And it's about stimulating them. They can be really difficult to understand and to read because they can't move their face. And not only that, but they're getting really frustrated with you because they're trying to tell you something and you can't understand them. So I've got a little case study for you. So we're just going to talk about Bob. So Bob is a 45-year-old patient. He is 85 kilos and 6 foot tall. He's been unwell for the last 2 weeks with flu, and he was admitted to Kentward with limb weakness. And now he's developed respiratory weakness, and he's come down for respiratory support. His vital capacities are currently 500 mils. Okay. His respiratory rate is about 35. He's unable to speak a full sentence because he's too breathless. His sats are 89% on 50 litres of oxygen via the breathe bag, by the non-rebreathe mask. He's very anxious. He's having some kind of a panic attack. So I'm going to put it to you guys, and either use your phone or you feel free to unmute and say something. Though I do like a word cloud if we can ever get a word cloud going. But from what I've told you about Bob, what do you think Bob needs? Huh?
First do your ABC approach and get a gas.
Yes.
And maybe possibly he will need the invasive ventilation. We can try with a non-invasive initially.
Actually, with Guillain-Barre, you shouldn't try them straight. We shouldn't try them in non-invasive because they're more likely to aspirate.
Okay.
So it's more you're completely right with your invasive ventilation. You don't see, and they don't often like non-invasively ventilating them. I suppose they could try high flow, maybe. There's a potential they might try high flow as an option.
Yeah.
Other things what you thinking about?
And he has to be immediately referred to the neurology team.
Get ready for intubation.
And then if the patient has not
Yeah, they need monitoring, don't they? He needs an arterial line. You're thinking about maybe inotrope, so you might need a central line. Yeah, wonderful. So yeah, no, I was thinking ventilation for Bob. I was thinking I'd check the bed space that he was going into, and I'd check I had a ventilator working, and I'd have a green bag or Mapleton C circuit, whatever you want to call it, that I had working suction, that I had airway adjuncts at my bed space, because if his swallow is impaired, I might get away with like a Goodell or an MPA airway, so I can suction him. I'd be thinking about preparing my ventilator. I'd be thinking about what drugs I need for intubation and also for sedation afterwards, because it's all very well giving him the paralysis and everything, but I need to have my propofol and my fentanyl prepared as well, don't I? So I'm thinking ahead to my intubation. I want to check the intubation trolley. Has it been checked recently? Does it have everything in it? Because although you like to assume it's been checked every shift, you might not have done. Has someone else used it 10 minutes before you, for example? I would also be telling the nurse in charge and the doctor that I have a problem.
nurse in charge. Always inform the nurse in charge.
Always, yes. And the reg. I personally would be above the SHO by this point, because I want intubation and I want someone who's airway trained. Yes. So now what I want to ask you guys is, what do you think Bob needs now he's ventilated? So we've taken Bob, we've done an intubation. He's a grade 1 intubation. Very good. And he's got the propofol and fentanyl running. So what are we thinking that Bob needs now?
Settings.
Ventilate, yes, and that's not on my list. Very
Settings.
true.
And then you can do another blood gas. I mean, what settings?
Blood gases. Let's put him on pressure support. No, sorry, he's on PSIMV. PRVC, PSIMV.
Depends on the.
Got a rate of 10. Pressure support of 15. Peak of 8. Other volumes are good.
Okay.
But yeah, what else would we be thinking for Bob?
Something.
NG. We thinking NG, yes.
Urethral catheter.
Catheter.
The one that the request for what you call that?
Chest X-ray.
ECG. Chest X-ray confirmation of the tube.
Yeah.
NGT. And then.
Meeting needs.
Sorry.
Meeting his nutritional needs. Refer to the dietitian.
Yes, absolutely, Hannah. That's on my list.
Pressure ulcer prevention protocols.
Yes, pressure ulcer prevention.
What you call that?
Laxatives.
And then
DVT. Yeah, Hannah. That's right. I think it's Hannah.
Yes.
I have to guess with the who's talking by the speaker. I'm getting better at hearing all everyone's voices.
Sorry, because the rhymes.
the eye, what you call it? Eye ointment.
Oh, we've got eye care and mouth care. Eye care in the room. I had eye care and mouth care. Yes.
Physiotherapy.
Yes. Sorry.
Physiotherapy, regular physiotherapy, and splints.
Splints. Yeah, we're thinking. I'm thinking OT and physio referrals. Absolutely. That is definitely on my list. Okay, I'll run through my list. You guys are doing really well here. I would check my cuff pressure. As I'd like to do that. I'd like to make sure my patient is in a good position to breathe in. So I want him sat up to 30 degrees. I want to be suctioning his chest. What can I hear? Can I hear both sides? I want the chest X-ray. Yeah, from a circulation point of view, have I got any blood pressure parameters? Well, I'm not sure whether there's an M there. Oh dear. It's another one of them late night presentations. My electrolyte imbalances, what's my temperature? Is he showing signs of infection? Is he showing signs of sepsis? This is the type of thing I'm thinking about here. Yeah, has the sedation knocked his blood pressure down too much? Is he peeing? Because if he's not peeing, he might need slightly high blood pressure, depending on what he's got. Neurological assessment. How often do I want to do my GCS? Well, I've sedated him. And I've got a Guillian-Barre patient who's not going to move.
Just the people.
I'd be interested in my pupils, yes. And potentially he's just started, he's just been intubated. So I'd give him the benefit. I'd probably check a little bit just to check, but I wouldn't be going all out. I'd be doing like a gentle, hello, can you hear me? And a little tap. And then writing down a GCS3. I wouldn't be going all out that sometimes you may have heard me do sometimes if I need to get a patient to wake up and I'm shouting and shaking them. or I wouldn't be doing the periorbital pressure. I wouldn't be pushing my limits because I know there's no point. I might do a gentle, half-hearted attempt at waking him up, but not a proper one. Is he on enough sedation? Is he showing signs of pain? Is he tachycardic because he's distressed and he can't tell me what's going on? Gut parallaxis we had in the room, DVT parallaxis, I'm sure someone said that, mouth care and eye care. And just mouth care is one of the really important things, because imagine how you would feel if people didn't clean your teeth for ages. But secondly, yeah, the chest infections caused by mouth care, there's been a lot of research into that. Limb positioning, yes, so the splints, OT, physio referrals, absolutely. Speech and language referral. Dietitian, yeah, an NG. And I'd also be thinking about immunoglobulins or plasma exchange. Although that's more of a doctor thing to be thinking about, and it's not something you have to consider. It's just on the list of actually that the immunoglobulins or the plasma exchange is going to be the thing that's going to shorten this plateau phase. So they usually like to start it quite early, and they will do the 5 days. So let's speak about Bob 5 days later. So what are we considering? So Bob's now been ventilated for 5 days. He's still on PSIMV. Not a lot has changed with him. He's okay. So what would we be thinking about? What are our priorities with Bob's care now? Optimization. Sorry, airway. Sorry, Hannah, can you just repeat?
Sure, he does not develop any kind of VAC because he's been on ventilator.
Absolutely. So any other infections? So you'd be checking his chest, suctioning him and looking at the consistency of it, checking his temperatures, skin condition, absolutely. Pressure sores, yeah. What else might we consider that we don't consider straight away? What might we
consider about tracheostomy?
Yeah, an early trachea would also be on my list. Thinking about an early trachea. I was thinking more pain. Yeah, is our pain under control? That is definitely there. I was going with things like your family. So family visits. Does he want to listen to music? What does he want? What's going to make a bit of stimulation for him? Yeah, kind of. So they're really good guys. So our chest management, yes. So our assisted coughing, our sputum clearance, our moving and rolling him, our sitting him up, the early trachea if we're going to need it. We know he's going to need a trachea for a long time. It's going to be a slow wean. So have we got any cardiac instability? What is his temperature? You know, is he showing any signs of sepsis, which we've had in the room? And pain, what's he got? Does he need more? Is he still in pain? Maybe the pain team would like to see him. I mean, there's some options there, isn't there? Sedation. Is he comfortable? Because if he's still got the ET tube in, you still need to give him some level of sedation. He may not have a cough, so he might be one of them patients just lays there, but actually he could be feeling really uncomfortable and you wouldn't know. GCS, so I'd now be on probably daily GCS. Not, and I wouldn't be waking him up at night for GCS. Mouth care and eye care, absolutely, yes. Reassurance, communication. These are not the patients that you talk over as you are rolling them about your day, about, you know, something else. they're also becoming slightly delirious and disorientated as well. So it's really important to tell them what's going on. We are going to roll you. I'm going to do this to you because they can hear you. Yeah. What music does he like to listen to?
How often are we doing GCS on him in this case?
I'd probably be on once per shift after 5 days.
Okay.
Maybe 4 hourly in the daytime just to show some willing. It's mainly watching for them subtle changes to see if it's starting to improve. Yeah. I'd be thinking about family visits. So yeah, and bear in mind that pre-COVID we used to have family come in every day, and post-COVID. So whatever we are allowed to have at the current point in time in the current climate for family would be good. Does that make sense? Day and night routines, some sleeping tablets so that he sleeps at night time, because actually you want him to sleep at night and not in the day. And if he can't see, and we do like to put these patients in a side room with no window, so it can really distort their day and night. So sleeping tablets, sometimes they like to give the patients melatonin to balance out the day and night, but that's quite an expensive drug. They don't like giving that often anymore. But melatonin, antidepressants, yes, we are giving our antidepressants for him. Bowel care, absolutely. We're giving him sedation, going to constipate him. We're giving him painkillers, going to constipate him. We're giving him feed by this point. Possibly not going to constipate him, but who knows what the feed does. Yeah. So your bowel care, skin care, yes. And any signs of emergence. So any shoulder shrug when you give him a suction, any eye flicker, any toe flicker, anything. So 2 weeks later, Bob has his trachea and he is off sedation. You noticed that he started to trigger the ventilator. So he started to try and breathe. So 2 weeks on, we've got a little bit of breathing going on from Bob. So what do you think Bob needs now? Or what are we thinking about with Bob?
Weaning.
Weaning, yeah, we're thinking about weaning, huh? What else would we think? He's awake now, he's off sedation. What would we be thinking?
More of family visits.
Sorry?
More of family visits.
More family, if we're allowed to, yes, please. What about if he's stable? Sorry?
Hoist him, make him sitting for a daytime.
Absolutely, that's just what I was going to say. I was going to say get him out of bed if you can. Obviously, there is a fine line between doing too much and things, but start thinking about getting him out of bed. Because once you've got someone that's in here for a long period of time, going out on the balcony is really beneficial for them. Yeah. We had a Guillian-Barre patient in bed 1 for ages, a couple of years ago, pre-COVID, and I took him outside on the balcony, and it was a really cold day, and he was Scottish, so he wanted to go outside, and he didn't mind the fact it was cold. But then he loved it so much that he insisted that every day that a nurse took him on the balcony. So once I started it, wasn't very popular. One of my least popular moments. Because the nurse, it was really cold, and some days it was like nearly snowing because it was January time. Yeah, so taking him outside is really important. So yeah, okay. Well done, guys. We'll just go through quickly. We've just got 5 minutes left, and I think we will finish on time again. I'm quite good at this. So trachea site position, trachea wound, is it okay? Is it showing sign of infection? Is it oozing? What does the inner cannula look like? How often are you changing the inner cannula? You know, all that stuff to do with the trachea and trachea management. Respiratory, are you starting to slow wean him? Possibly, yeah, I would want to start. So if I'm seeing some signs of improvement, I'd want to be thinking about weaning him a little bit now. But obviously slow. Cardiovascularly, any signs of infection, any electrolyte imbalances for him. Neurological, daily, don't cause them pain. You know that he's going to be slow to progress. There's no point causing him pain. Stimulation, does he want to watch the TV? Does he want to watch radio? Or then take him on a chair, take him for a road trip. Does he want to be in a side room to help him with the day and night and the sleep? Some patients like a side room, some patients don't. Because although the side room can be really good for quiet. It can also enhance the feelings of loneliness and vulnerability. Mouth care and eye care, absolutely. Repositioning, so your splints that we mentioned, that someone mentioned earlier, your limb strength is all really important in there as well. Reassurance, yes, absolutely. Talking to them, giving him the motivation to carry on as well. And that comes from the nurses saying, come on, why don't you try this? Or if you do this for me, then I'll sit with you, I'll hold your hand, so that they don't feel as scared and alone. And then they're much more likely to do things for you. So it's about that ability we have as nurses to build that rapport with the patient where they then trust you. And if you've got the patient that's trusting you, they're going to be more receptive to doing more from a point of view of a rehabilitation. So communication aids, them balls that we like, where they look at the letter, giving him a notice board with the date and time on it to orientate him into it is really helpful. Giving him a clock so he can see what time it is. Again, important. Yes, and by this point as well, he may have a personalised care plan. So from a point of view of a patient's perspective, if they know that they're going to have a wash at 9 o'clock in the evening, that they're going to go to bed at 10 o'clock, that they're going to have a roll at 3 a.m, that in the morning time, they're going to have their meds and they're going to have a turn at 6 a.m, and then their rehab and their physio is going to come at 10 o'clock. So giving them a structure to their day is really important. And if they have a personalised care plan, it can have things in there like likes to watch the football, likes to watch the sport. And it just means that each time the nurses change on shift, the patient hasn't got to try to communicate their needs and their wishes with you because they've already written down. Yeah. So you know what radio station he likes to listen to, what time he wants his wash, what does he like and how does he like it? Does he want a cold bath? Some of them like a cold wash. Does he want a warm wash? And he hasn't got to retell the same thing to a different nurse every shift. And these patients quite often find that because they can become quite institutionalized as well, especially, I mean, 2 weeks is quite early, but the further along down the line they get, they'll have their favorite nurses. Yeah. And if they have a nurse that they don't like, then it's not as good. So, and it's about them early introductions with them patients and how they perceive you at the beginning, because they are very quick to form opinions. And they're quite rightly too as well. They have to decide whether or not you're trustworthy right at the beginning. And if they decide they don't trust you at the start of your shift, good luck with that one. Yeah, it's very similar to your spinal patients. They also develop a really good ability to click. And
Yeah.
the
pressure.
Yeah, the patient will
yeah.
do like that.
It keeps on shaking.
Yeah. It's your spinal patients and Guillian-Barre patients. They're taught. We think the speech and language therapists teach them to click. I did say that I would like to click in the year of a speech and language therapist every hour of a night time, but I don't think I'm ever going to be allowed to do that. Anyway, so finally, just moving on. So months later, Bob comes back in to see us because they quite often do, because it orientates them. They can see what the intensive care unit's really like, because it's never how they remember it. And they like to see whose voices they know and whose faces they recognise. And so they like to come back for their own point of view of clarity and closure. Always come back. And he's nearly walking. He's on his way to making a full recovery, is Bob. So we've done well with Bob and he's doing really well. He's still got a little bit of a limp, but he's doing okay. And yeah, okay. So I'm going to exit my screen share. I am going to go back into Teams. And I'm going to stop sharing my screen, and I'm going to I'm going to end the recording.